Thanks so much to everyone who's joined today. Dr. Ward, are you back on? Joanne, would you like to kick it off?
Okay, I'm not sure what's going on with Dr. Ward's sound, but first of all, I would like to welcome everyone for coming to this NIH webinar series on moving from hepatitis discovery to elimination. And the topic today is improving early detection of HCC, the quest for new biomarkers. And before we begin, we have the distinct pleasure of having Dr. Doug Loewy, who is the National Cancer Institute's
I'm back on
I think John's sound is still not where we want it. So if I could,
Joanne,
yeah,
this is Doug. Is my sound okay?
yes, your sound is perfect. Yes.
Okay.
I would like to introduce Dr. Loewy, and he has been the National Cancer Institute's Principal Deputy Director since July of 2010. And he's helping to lead NCI key scientific initiatives. And he has also served as the acting director between April of 2015 and October 2017, as well as April 2019 through October 2019 at the NCI. And his research interests include the biology of papillomavirus and the regulation of normal and neoplastic cell growth. And he has many honors and awards, and most recent honor is the 2020 American Association for Cancer Research Distinguished Public Service Award in recognition of his outstanding leadership of NCI during his term as acting director. So, Dr. Loewy, would you like to say a few words?
Dr. Renato, thanks so much. I want to thank Dr. Ward, Dr. Renato, and Dr. Knoll for organizing this series and the session. And Lindsay, why don't you put the title slide up again? This series is really aimed to try to stimulate more research, bring everyone up to date on what is happening in different areas of hepatitis-related research and also hepatocellular cancer. We wish that there was nobody who was developing hepatocellular cancer, and that's on some level what the series is reflecting in terms of the overall aspirational goals. But we know that there are people who are at high risk of developing HCC and who will develop liver cancer. And the problem for this group of people, in addition to developing cancer itself, is that the vast majority of them are going to have their cancers detected at a relatively late stage of their cancer, when it is much less treatable than it would be at an early stage. And therefore, this afternoon's session is really focused on what is going on in the research space and what is the current status of trying to improve early detection of HCC, with a particular emphasis on biomarkers. We have 5 different presentations, each of which looks at this issue from a somewhat different perspective. I don't want to take time away from the presentations, because in addition to listening to the presentations, it's always interesting, both for the presenters as well as for the people who are online listening, to be able to have time to ask questions and make comments. So I'm going to turn the session back over to Dr. Renato, and really want to thank all of you for joining, and thank the speakers for their active participation as well.
Thank you, Dr. Loewy, for your introduction. I would just like to make a few comments to the registrants and participants in that all questions need to be sent via the chat box. And depending on the time remaining after each presentation and the number of questions received, several questions may be asked of the speakers. So with that, I would like to introduce our first speaker, Dr. Catherine Mcglynn. And Dr. Mcglynn is a senior investigator in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute here in Bethesda, Maryland. At NCI, she is studying HCC in US populations, and she has organized the Liver Cancer Pooling Project that brought together cases from a number of longstanding and North American cohorts. And most recently, she has been conducting investigations on non-alcoholic fatty liver disease and liver cancer in Central America. Dr. Mcglynn? Oh, I think you're, there we go.
Thank you very much, Joanne, John, and Betsy for the kind invitation to speak. Let me see if I can get my slides up here and get it so everyone can see them as well. Can you see them now?
Yes.
You should need to switch it from presenter view.
Oh, yes, you're.
Oh,
yeah.
let me switch them over then. Yes, how's that? Better?
Very good.
Great. So primary liver cancer, the great majority of which is hepatocellular carcinoma, of course, is one of the major cancers in the world today. It is the 6th most commonly occurring cancer, and due to a very poor prognosis, as Dr. Loewy said, it is the 3rd largest contributor to cancer mortality. This is the Glycan 2020 liver cancer incidence maps. Countries shown in the darkest blue colors here are the ones with highest incidence rates. And it's no surprise to individuals who are participating today that these high rate countries tend to show up most noticeably in East Asia and in Africa. I'd like to point out there's also a nexus of high risk countries in our part of the world, which are in Central America and in the Caribbean. But of these 3 regions, the one that really bears the brunt of the liver cancer burden is Asia, because over 70% of liver cancer arises in Asian countries and over 45% alone in China. In contrast, it's been estimated by IARC that Africa and Latin America are home to about 12% of liver cancer. But please keep in mind that most countries in these areas are low and middle income countries. And so these countries are least able to deal with this burden they bear. In all parts of the world, liver cancer is or tends to be more common in males than females. In some areas, such as Western Europe, the discrepancy in rates is even more pronounced, 4 to 5-fold higher in males. Whereas in the country that probably has the highest rate of liver cancer in the world, Mongolia, the rate is only 1.6 to 1 males to females. And this discrepancy we see in Mongolia is not unique to that country. In Central America, South America, we see rates that are very close to 1 to 1, starting in Mexico in the north down to Chile in the south, under 1.5 to 1. So we don't know why this varies worldwide and why we're seeing this in the Western Hemisphere, but with our research in Central America, we're hoping to get a better handle on it. In terms of trends, now this is Hcc Trends. We published this a few years ago using data from cancer in 5 continents. And the trends, unfortunately, were quite unfavorable in many countries. And there are the countries shown here in red. We saw rising rates in Southern Europe, Northwestern Europe, North America, and South America. In contrast, there was a little bit of good news here in Eastern Asia, where rates were coming down in China, Japan, and Korea. So we also saw one other very favorable trend, which is right here in Southern Europe. Italy for many years has had the highest rates in that region, and rates about 1990 started coming down in Italy as well. So all things considered, there were a few silver linings around these very dark clouds of the rest of the world. In North America, unfortunately, in 2012, the rates in the United States were the highest of the other registries that we could include. But let's fast forward those data to 2018 and see where things stand today. So as with other countries, rates among men are considerably higher than rates among women. Unfortunately, we also see this disparity in rates by racial ethnic group in the US, with all groups in comparison to non-Hispanic whites having about double the risk, which is extremely unfortunate and something that we need to pay more attention to. In terms of age, of course, the US and other westernized countries, HCC tends to be a very rare cancer under age 50, but goes up thereafter. So the median age at diagnosis in SEER now is about 63 for males and about 5 years later for females. So you see that the bulk of HCCs in the US that are diagnosed are in persons who are in this middle age group. Well, there is a little bit of good news here for HCC incidence that has really come around since our publication of the 2012 data. As you can see here, rates of HCC, this is not all liver cancer, this is specifically HCC, rates began to drop around 2014, 2015, very subtly, but statistically significantly. So that this line in the middle, that's the black line, is everyone together, significant drop in rates that occurred amongst both males shown on top and females shown on the bottom. It occurred in most racial ethnic groups. Unfortunately, it did not occur, though, among American Indians, Alaskan Natives. And we also saw a drop in incidence in all three age groups that I mentioned previously. A more pronounced drop, admittedly, in the younger groups, but still a drop in the other groups. The incidence rate pattern has been followed by drops in mortality rates. And of course, mortality always lags behind incidence, but we are beginning to see drops here in mortality as well. So I think these are very promising signs of what's to come. We had really anticipated that rates would continue to increase for a decade or so, or even more in recent papers, but I think those expectations, we hope, will not be realized. In terms of prognosis, however, as Dr. Loewy just mentioned, the survival statistics remain quite poor for liver cancer. So this is all liver cancer combined, all stages combined. You can see here that the 5-year survival in the United States is at less than 20% now. So clearly not where we need to be with really combating this, this fatal cancer. Of course, if you are able to diagnose at an earlier stage, you have more favorable survival. So 5-year survival for local disease is about 34%. In comparison, for distant disease is a very dismal 2.6%. So I think this is really the best data you could use for my colleagues' talks, which are going to focus on the development of better biomarkers, we hope, and also for diagnosing earlier with early detection methods. So I will leave those areas to them. But I would like to point out that in the United States, although we have extremely poor survival, in other parts of the world, it is even worse. So these are data from sub-Saharan Africa. 5-year survival is only on the order of about 3% here. And unfortunately, as again, Dr. Loewy mentioned, most individuals show up with advanced tumors that are not amenable to treatment at all. So these statistics, unfortunately, are true of many low and middle income countries around the world. So if we could turn to HCC prevention for a few minutes. Obviously, if we're going to do something about HCC, we have to do something about the risk factors that are driving it. And this is a list of some major risk factors with the population attributable risks that were estimated a couple of years ago by a group in Europe. What they estimated was that about 44% of the HCC in the world is linked to HBV, about 21% to HCV, 17 to 28% to aflatoxin, about 26% linked to alcohol, 13% to tobacco. They estimated that less than 10% was linked each to obesity and type 2 diabetes, but I think these estimates are really low and will have to be revised upward very shortly. Keep in mind, of course, that these population attributable risks are a global average, and all the risk factors do not have the same prevalence in all countries. So as we know from the CDC's maps, HBV and HCV prevalence vary greatly by country. So the approach to dealing with risk factors in different areas of the world is going to have to be different. But what is the evidence if we do something about these risk factors, we really can prevent HCC? Well, taking a look very quickly at a few of them. The first question is one that's probably been discussed in this webinar series already, is does HBV treatment have an effect? Clearly, this would be an avenue we'd want to go because there are 260 million people who are chronically infected in the world today. And our ability to treat individuals was improved about 20 years ago with the dawn of the nucleoside-nucleotide analog era. The evidence that we can do something about it, well, I am going to borrow from Dr. Anna Locke here, looking at some data that she published almost 20 years ago now, 10 years ago, looking at the effect of treating HBV carriers and showing that there was a decreased risk of HCC in individuals, whether or not they had a viral response to treatment. So clearly, I am greatly oversimplifying this issue because there are a lot of factors that go into who you treat and how long you'll need to treat. But I think this is at least some hopeful information that treating individuals who are already infected will have an effect on HCC. But of course, it goes without saying that we don't want to be putting all of our attention on just treating carriers. We want to prevent people from becoming carriers. So in order to do that, of course, we have a vaccine which has been around since the early 1980s. And the evidence that the vaccine will have an effect on rates is actually pretty good, because there is a group in Taiwan that has been following what's going on in their country for many years. Taiwan instituted nationwide neonatal vaccination in the mid-1980s, and they have since been comparing rates of HCC in individuals who were born pre-vaccination era to individuals born during the vaccination era. And their rates look fairly impressive at this point. Now, this is a paper that came out in 2013. It's a little bit out of date now, but as you can see, already by this time, the rate of HCC in males born pre-vaccination era was considerably higher than the rate born among males in the vaccine era. And we see the same is true of females, although of course they have lower rates. It's a little bit harder to see the improvement. But I think this bodes very well for the future of vaccination. Please keep in mind, though, this is a neonatal vaccine, so individuals who are vaccinated are still in their early 30s. And although they had high rates already, you can see here going into their 20s, they won't see the full effect of vaccine in most countries for another 30 years yet. So there are things still to do as we wait to see what happens. In terms of HCV, of course, the advent of the DAA era about 10 years ago really improved outlook in HCV and its ability to cause HCC. So at first, things looked a little bit concerning because there was some evidence, in fact, that risk of HCC went up among individuals who were put on the DAAs. But I think better designed studies really allayed that fear. This is one from the VA that compared the risk of developing HCC among individuals who were put on interferon therapy alone, individuals who went on interferon therapy and then a DAA, and finally DAA alone. And as you can see here, there was a reduced risk of HCC in all three groups. So the take-home message here is that HCV eradication works. It doesn't matter how you get there, there is a reduced risk of HCC with HCV eradication. But of course, it does not completely return that risk to zero. That is not the case, so some follow-up will be necessary, but the greatly reduced risk is, again, certainly promising. Turning to aflatoxin, this is an important risk factor in parts of the world that have warm, humid climates. So this is the aflatoxin belt around the world. This is where the mold grows most readily, and unfortunately, with global warming, this belt may get wider in the coming years. But what is the evidence here that you can do anything about aflatoxin? Well, the best evidence comes from a natural history experiment that took place in China in the mid-1980s. At that time, in the Jiangsu province, north of Shanghai, there were a population of individuals that were living on a maize-based diet. In the mid-1980s, the government changed policies in the area. They allowed people to import rice. And within about 3 years, the entire dietary structure in the population had really changed. So the majority of the people were consuming rice, and rice is not susceptible to aflatoxin contamination. So as you can see here, individuals were being followed with serial samples looking at aflatoxin albumin addicts. There was a 40-fold decrease in levels in a very, very short period of time. At the same time, roughly, there was a 45% reduction in the liver cancer mortality rate in the population. Now, admittedly, this is ecologic data. It's not cause and effect relationship I'm showing, but the likelihood is most of this decline was related to aflatoxin. Because if you look here in the middle, you'll see that HBV carrier rate did not change in the population during this time. So it's very likely that this decline in aflatoxin really had a major effect on rates. And probably one of the reasons that it had such a profound effect is that aflatoxin and HBV, unfortunately, have a synergistic effect on risk. So if you get rid of one of these components, you will not simply reduce in an additive fashion the risk associated with it. You'll get rid of this synergistic effect and really have a major impact. So I think that what we're seeing there really bodes well for being able to put some effort into aflatoxin contamination, particularly in areas of the world where HBV is also a factor. In terms of alcohol, very briefly, there have not been many studies, but those that have been suggest that it takes a while for risk to get back to where it would have been amongst non-drinkers. In fact, it takes a couple of decades, but the risk will decline if people who drink excessively stop. Same is true of smoking. This is analysis we did in the Liver Cancer Pooling Project. You can see here there's a decline in risk over time from the time of smoking cessation. But again, it takes a couple of decades for it to get to what it would have been in non-smokers. The group of risk factors that are probably most important, though, in the world and will be increasingly important over in a few years are the group of metabolic disorders. So this is the prevalence of non-alcoholic fatty liver disease in the United States now, and it's really rather alarming. These are using NHANES data from the most recent survey. We found here that overall 48% of the population had non-alcoholic fatty liver disease based on FibroScan determination. Unfortunately, some segments of the population, including persons of Hispanic ancestry, had over 50% prevalence of NAFLD. So this is quite concerning from a public health perspective. And of course, this increase in NAFLD in the US and many countries is very closely tied to the global increase in obesity rates. So this is from a review article that came out last year. The blue bars are men, the red bars are women. You can see over time from 1980 to 2016, obesity prevalence has shot up dramatically. And if I were going to show you type 2 diabetes, you'd see very much the same thing. The epidemic of type 2 diabetes is really profound in the population now. So the ability to do something about this, well, we don't have a lot of data on how to affect HCC rates by controlling obesity. A little bit of suggested data that will come from these studies of bariatric surgery. This is one we did a few years ago that found a significantly reduced risk with bariatric surgery in a large hospitalized population. And just recently, a paper that was published in Gastro came to the same conclusion, a significantly reduced risk. Now, of course, bariatric surgery is not a solution for most people and cannot even be offered to most people, but it is still some suggestion that reducing weight will help. In terms of diabetes, of course, most of the effort has been gone into looking at specific diabetes medications. We see here that meta-analysis suggests that the use of both metformin and TZDs are associated with decreased risk among individuals with diabetes. So although these are growing problems, there may be ways to tackle them in years to come. So let me stop my remarks by giving a little summary in which I would reiterate that there is reason to be hopeful for rates of HCC around the world, because we have seen that rates are declining in the Eastern countries, in Eastern Asian countries. And it looks like rates are starting to decline in the US. Rates are still high, though, unfortunately, in the other areas of the world I showed you, and I am including here both Africa and Latin America, where we don't even have a good handle on what the rates are because of the lack of really good high quality registries. So if we are to make continued progress on HCC, however, we have to really tackle a number of issues. One is in the US to get a better grip on the racial ethnic disparity in rates and how we can reduce that gap. Around the world, we have to do something about HPV vaccination programs that aren't up to performing where they need to be. And in this case, I think HPV vaccination programs in sub-Saharan Africa really could use some help to make sure that their neonates get the first dose into them and all subsequent doses. We need to be able to identify chronic carriers, of course, of HPV and HCV around the world and make sure they have access to medication that's oftentimes out of their reach. For aflatoxin, pre and post-harvest eradication programs have been developed. There are dietary interventions as well that we need to look at more closely. Smoking cessation works and is beneficial for other outcomes as well, of course. We need to really identify new avenues to decreasing obesity, because clearly what we're doing with obesity control is not having the result that we would hope. So more attention needs to go here. And in terms of diabetes, keeping individuals on their medications, and again, making sure they have access to medications, which is often not the case in many settings, would be beneficial. Finally, for HCC mortality, I think it's very clear from the survival statistics that we need to do a much better job at early detection, and we will get there faster if we have better biomarkers. This is particularly true, again, in low and middle income countries where they have no access to things such as imaging at all. They are totally dependent on biomarkers, and most people are not benefiting there at all from advances we've made in the higher income countries. So our attention to better biomarkers, I think, will pay off in major ways in the future. So with that, I will stop my remarks there and show you my beautiful building in Rockville. Thank you.
Thank you, Dr. Mcglynn, for a wonderful presentation. We have some questions. I see here in the question and answer box here that first question is, do HCV obese / diabetic patients have a higher incidence of do they have a higher incidence of HCC after SVR than non-obese diabetics? Do HCV, yeah.
I honestly don't know the answer to that question. Perhaps some of our other colleagues have looked at that more closely, but I have not broken it down into that finite categorization.
I can, from my perspective, the studies that I've seen have suggested that these are synergistic factors. So the more factors you have, the higher incidence of HCC. And so even after SVR, if you have diabetes and obesity, you can have continued sort of NAFLD, and the risk of HCC would be higher in that subgroup.
Yeah, this is my impression also that some of the data presented at ILC only last week also indicate the same thing. Diabetes remains a risk factor for continued presence of HCC in Hep C patients after SVR.
Yeah, and the one thing to note is that even though these factors can moderate your risk of HCC, I think in general, we haven't found a subgroup that is not sufficiently high risk to warrant exclusion of surveillance. So put it simpler, after SVR, if you have cirrhosis, all those patients should undergo surveillance because the risk is sufficiently high. So you shouldn't use these other factors to decide to do surveillance or not.
Thank you. Thank you. I'm going to move on to our next speaker. There are some other questions here still in the chat box that can be answered by Dr. Mcglynn, or we will have some time at the end of all the presentations for additional questions. Our next speaker is Dr. Amit Singhal. Dr. Singhal is a professor of medicine and chief of hepatology at UT Southwestern Medical Center in Dallas, Texas. He is an expert in hepatocellular carcinoma management, and his research focuses on prevention, surveillance, and treatment of liver cancer, including evaluation of interventions to improve early tumor detection and to reduce liver cancer-related mortality. Dr. Singhal.
Thanks, Joanne. I want to start by thanking the Coalition for Global Hepatitis Elimination and the NCI for inviting me to be a part of this panel. Quite an honor to be a part of this panel with all of the other esteemed speakers. As you can see, today I will be speaking about Hcc screening, current practices, and then towards the end, and I'll be discussing some future directions of where we hope Hcc screening will go, to really talk about some of the aspects that Dr. Mcglynn talked about in terms of reducing mortality as we move forward. Next. So here you can see my disclosures. I have labeled the one slide that it's relevant as a COI. Next. So as you heard about, nicely from Dr. Mcglynn over the last 15 minutes, this is a simple schematic in terms of how somebody gets to HCC. Typically starting life with a normal liver, they can have one of the many insults that Dr. Mcglynn covered to develop chronic hepatitis. We know that there are some subgroups such as hepatitis B, and now recognizing about a quarter of patients with non-alcoholic steatohepatitis can go directly from chronic hepatitis, typically advanced fibrosis, bypass the cirrhosis step and develop HCC. However, recognizing that over 90% of people in the Western world and the majority of people globally develop HCC once somebody has cirrhosis. And once somebody has cirrhosis, they have an annual risk of developing HCC somewhere around 2% per year. And this risk persists after SVR, as we just discussed, and also exists in patients with non-viral liver disease once they develop cirrhosis. Next. So given the high risk of HCC when somebody has cirrhosis, professional society guidelines have recommended HCC screening in several high-risk groups. And so when you take a look at this, there are subgroups of patients with hepatitis B, including patients with vertical transmission, males over the age of 40, females over the age of 50, hepatitis B carriers with a family history of HCC. And then, for many of the reasons that Dr. Mcglynn discussed already, we typically recommend HCC screening at a very young age in African or North African Blacks with chronic hepatitis B. And then you can see that the rest of the high-risk subgroups really are those with cirrhosis from any etiology, whether viral hepatitis or non-viral etiologies. Now, the one thing to note at the bottom of the slide is that there are some subgroups in whom the benefit of surveillance is uncertain. And these include patients with advanced fibrosis, whether related to hepatitis C or NAFLD. But the current data suggest that it's unlikely to be a benefit in those subgroups at this time. Next. So, these are the professional society guidelines. I always think it's helpful to take a look at the data that supports these recommendations. The best data for HCC screening comes from a large randomized control trial that was conducted in China now over 15 years ago. Over 18,000 persons randomized to receive HCC screening or not. And you can see from the table that the proportion of patients found at an early stage significantly higher in the screening group, 60% versus 0%. The proportion that underwent curative treatment significantly higher at 47% versus just under 8%. And most notably, this is the best data that we have that HCC screening reduces HCC-related mortality with a 37% reduction in HCC-related mortality in this large randomized trial. Next. Now, unfortunately, we don't have similar randomized data in patients with cirrhosis. When a large randomized trial was attempted in patients with cirrhosis, this actually had to be shut down early because both patients and providers refused to have a chance at being randomized to the no screening arm. And so we're forced to depend on cohort studies, taking a look at the association between Hcc screening and improved outcomes. So here you can see a systematic review and meta-analysis that we published just over 5 years ago, taking a look at 47 studies with over 15,000 people, with about 40% of those being detected by screening. And you can see that screening was associated with increased odds of early detection, increased odds of curative treatment, and most notably associated with improved survival. Now, we know that these cohort studies can have notable biases, including lead time bias and length time bias, but even those studies that statistically adjusted for these known biases, we saw a persistent association between Hcc screening and a survival benefit. So although imperfect, the data that we have do consistently suggest that Hcc screening improves survival in chronic hepatitis B, as well as patients with cirrhosis from any etiology. Next. Now, the next question is, how do we do Hcc screening? And professional society guidelines currently recommend an abdominal ultrasound with or without a serum biomarker called alpha-fetoprotein. And these two tests should be done every 6 months in these at-risk subgroups that we've already discussed. Next. These tests have actually been the backbone of Hcc screening now for over 15 years. Now, there has been a debate if we should be doing ultrasound alone or ultrasound with AFP. And so for the next couple slides, I point to some of the data that informs this debate of ultrasound alone or with AFP. When we take a look at the sensitivity of ultrasound alone for early stage Hcc detection, you can see here many of the studies that have looked at this, and you can see that the sensitivity of ultrasound for early stage Hcc detection varies widely by center to center, going all the way down to around 20% and all the way up to 80%. However, when you take a look at the pooled sensitivity for early stage detection, the sensitivity of ultrasound alone is less than 50%, with a pooled sensitivity of 47% for finding Hcc early. Next slide. And now the question is, why is this the case? And when we take a look at this, we actually find that part of the reason is that ultrasound actually doesn't visualize the liver well in about 1 in 5 patients. So this was a large study that we did about 4 years ago, taking a look at about 1,000 patients undergoing Hcc screening with ultrasound. And we had radiologists take a look at those ultrasounds and classify them into these 4 different groups: definitely inadequate, likely inadequate, likely adequate, or definitely adequate. And you can find that overall 20% of patients actually were deemed definitely or likely inadequate in terms of visualization of the liver for exclusion of liver masses. And what's concerning is that when you take a look at the patients who are at the highest risk of having a poor visualization on ultrasound, we find that those patients with obesity, those patients with alcohol-related cirrhosis, or NASH-related cirrhosis have a higher risk of having poor visualization on ultrasound-based screening. And this is concerning because some of the trends that Dr. Mcglynn already talked about, this is where the world and Hcc screening is going. We're dealing with an increasingly obese world and more patients who have metabolic syndrome or alcohol-related liver disease. And so it suggests that ultrasound is going to become more and more problematic and likely inadequate when used alone. Next slide. So now the question is, if ultrasound isn't adequate, what else can we use? And I actually believe that CT-based screening is probably not a viable option for multiple reasons. But if nothing else, we know that this can be associated with harms, including ionizing radiation, as well as a risk of nephrotoxicity, which is particularly concerning in patients with cirrhosis. And so once again, I would argue that CT-based screening is likely not a viable strategy, particularly if repeated at regular intervals. Next slide. In contrast, MRI-based screening may be viable if we can figure out how to do this. So when we take a look at data supporting MRI-based screening, there was a prospective study that was conducted in South Korea with over 400 patients who were followed by both ultrasound and MRI over a period of 1.5 years, over 1,000 screening rounds during that time period. So during that 1.5 years, patients had both semi-annual ultrasound and semi-annual MRI done. And there were 43 people diagnosed with HCC, 42 of whom were found at an early stage or very early stage. And so when you see here, the performance characteristics of MRI versus ultrasound, MRI had significantly higher sensitivity, 86% versus 28%, as well as higher specificity, 97 versus 94%. So very early data that suggests that this may be a strategy that appears promising. But of course, we have to figure out how to actually make this cost effective if we were to apply this to a broader group of patients outside of a clinical trial setting. Next slide. So now you can take essentially a 45-minute diagnostic MRI and consider shrinking this down to like an abbreviated MRI. So selecting certain sequences from that MRI and thereby shrinking that 45-minute exam to a 15-minute exam. And there now have been some early data, and this is stressed early data, that basically suggests that abbreviated MRI can retain high accuracy for early stage HCC detection. You can see 4 of those studies summarized in this table here. And overall, the sensitivity of abbreviated MRI protocols ranges from 80% to about 90%. And similarly, the specificity is somewhere between 89 to 95%. So early data suggesting that this is promising. We do need better, cohort data before this should be used in clinical practice. We also have to determine things like how we would bill for this in clinical practice. Right now, my understanding is many centers, even if you get an abbreviated MRI, you still get charged for the full MRI, and thereby it obviates a lot of the benefits of going to an abbreviated strategy. So lots of things we have to figure out, but at least some promising early data. Next slide. So as we figure out, what other alternative imaging modalities may exist, you already heard from Dr. Mcglynn that there's a lot of interest in biomarkers, and I know you're going to be hearing from Dr. Mehta next in terms of some of the promising biomarkers that are being evaluated. Alpha-fetoprotein is the biomarker that has the best data as of today, and the current data suggests that this does appear to be of benefit when added to ultrasound in terms of Hcc screening. So on the left-hand side of the slide, you can see the studies that have compared ultrasound alone versus ultrasound with AFP. And you can see that the sensitivity of the combination is significantly higher than ultrasound alone. And so the combination has a sensitivity of 63% versus ultrasound alone, 45%. This was offset by a small decrease in specificity, but overall the diagnostic odds ratio, i.e. the overall performance, was higher with the combination than ultrasound alone. We subsequently have performed a cost effectiveness analysis that has compared ultrasound with AFP versus ultrasound alone versus no screening. And in that updated cost effectiveness analysis, ultrasound with AFP was the dominant strategy in the vast majority of simulations, and so suggests that ultrasound with AFP is the most cost-effective strategy at this time. Next slide. Now, I say that ultrasound with AFP should be the strategy now, a little bit of a hint in terms of where we need to go, and you're going to hear much more about this from Dr. Mehta, but there are many biomarkers that are currently undergoing phase 2, phase 3 biomarker evaluation, some of them being listed here, but hopefully, if we were to talk about this from, 2 to 3 years from now, we'll be talking about some of these novel biomarkers and not just AFP. Next slide. There have been increased interest in biomarker panels, which actually combine not only a single biomarker, but demographics in combination with multiple biomarkers. And this hopefully will increase the accuracy of detecting HCC at an early stage. Now, this is the slide that's labeled with my conflict of interest, as you can see. I do consult for this company, although was not involved in this specific study. This is a nested case control with just under 7,000 patients who were evaluated by this biomarker panel called GALID, combining gender, age, and these 3 biomarkers, AFPL3, AFP, and DCP. And you can see here that GALID actually achieved very high sensitivity for early stage HCC detection when used alone, somewhere between 60 to 80% with a simple biomarker panel used alone. And these are early data, once again, case control data. We need this to be evaluated in large cohort studies, but at least promising data that biomarkers have a path forward to improving HCC screening in the future. Next slide. Now, the nice thing is that, you know, the Early Detection Research Network and the NCI have actually established large cohorts, which allow us to do phase 3 cohort evaluation. One of those being the hepatocellular carcinoma early detection strategy study. This is a study with over 1,500 patients being followed at multiple sites throughout the US, 87 incident HCC, and multiple biomarkers are currently undergoing phase 3 biomarker evaluation using this cohort. And so this cohort is now matured. We anticipate data coming out later this year to evaluate some of these novel biomarkers that you'll hear about from myself as well as over the next couple talks. Next slide. Finally, I want to end with one last thing. I mean, you know, we've talked about how we should do screening, how we can improve screening, but honestly, the most important thing is that we do screening, that we do something. And unfortunately, Hcc screening continues to be underused in clinical practice. So when you take a look at-risk patients, particularly those with cirrhosis, we find that only 1/4 of patients actually receive screening at this time. And this is an area where the US is actually lagging behind the rest of the world. So when you take a look at screening in the US, it's 18% versus 40% in Europe and 35% in Asia. So clearly we need to do better. It doesn't matter what we have if we're not actually implementing this in clinical practice. And so, so we find that people who are being followed by GI hepatology subspecialists or in academic centers tend to get higher screening utilization, but still far from where we need to be. Next slide. We find that one of the biggest barriers in terms of having Hcc screening done is actually many people who present with Hcc do so new, meaning they're actually not being followed in clinics prior to their Hcc presentation. And so this is actually one of the things that we have to do is to improve Hcc screening is doing a better job of identifying these at-risk people in the community, patients with non-alcoholic fatty liver disease, patients with viral hepatitis, identifying those with cirrhosis and getting them into care so we can actually implement the screening. So this is actually one of the biggest barriers that is probably going to be the hardest to address to improve Hcc screening utilization in the future. Next slide. Now, when we take a look at those patients who are in academic practices or actually in care, there still is underuse of Hcc screening, and we find that both patients and providers report multiple barriers to getting Hcc screening done. This was a study that we did with over 150 primary care providers, and we find that the actual barriers reported by providers include lack of knowledge about guidelines, competing interest in clinic with a lack of time to perform screening, and difficulty recognizing at-risk patients. These are all barriers that we have to think about and address if we want to have Hcc screening used more in the future. Next slide. We also find patients report multiple barriers that translate into lower Hcc screening adherence. This is once again a survey study that we conducted over 3 health systems, over 1,000 patients that completed this survey. And we find that the most common barriers are those listed on the slide: cost of testing, difficulty getting the scheduling of the ultrasound, uncertainty where to get the ultrasound, and difficulty with transportation. You can find that there's small variations in how commonly these barriers are expressed over different health systems, but despite that, these are the most common barriers. And most notably, when you take a look at in the chart and you take a look at screening completion, these patient-reported barriers translate into lower screening utilization in clinical practice, suggesting these aren't just patients complaining. These are true barriers that we need to address once again if we want to do better in the future. Next slide. The good thing, and this is one of my final slides, is that the interventions that we do have and that have been evaluated appear to show promise to increase Hcc screening. These range from things like primary care provider and patient education. These include electronic medical reminder systems, recall systems, and mailed outreach strategies. But in short, no matter what the intervention that's been evaluated, all of them have shown some benefit to increasing Hcc screening. So the good thing is we have a blueprint of how we can do better. Now it's just a matter of implementing these interventions in clinical practice. Next slide. So in summary, Hcc screening is supported by a large randomized trial in patients with chronic hepatitis B, also supported by several cohort studies in patients with cirrhosis from other etiologies. We know that test accuracy and actual screening utilization are the key factors to maximize effectiveness in clinical practice. I would argue that ultrasound alone has suboptimal sensitivity for early stage Hcc detection, particularly in contemporary cohorts. So this argues that right now, ultrasound with AFP every 6 months should be our current strategy. However, we still need to do better. Novel blood and imaging-based modalities are being evaluated. I anticipate better data coming out over the next 1 to 2 years. So hopefully the field will continue to move forward. And then clearly screening is underused in clinical practice. This is related to multiple barriers, including patient and provider related barriers. And intervention strategies show promise to increase utilization. I think we just need to figure out how to implement them in clinical practice. With that, I'll end and happy to take any questions. Oh, actually, before I do so, obviously the work that I presented is related to a large team. And you can see several of them listed here, several of them also probably not listed here, but many people that I am eternally grateful for. And then of course, the NCI for all of their support to fund these studies and really advance liver cancer early detection and prognosis. Once again, I guess the last thing I'll say is Liver Cancer Awareness Month is October. It's often overshadowed because it's also the same month as breast cancer awareness. But liver cancer is rapidly rising in terms of mortality. So hopefully more and more awareness that October is a month we should wear green ribbons as well as pink. Thank you.
Thank you, Dr. Singhal. There are a number of questions. Before I give you some of these questions, there was one about, could someone please email Dr. Singhal's slides? Now, just to let everyone know that the CDC website has a web page devoted to these webinars on hepatitis moving from hepatitis discovery to elimination. You will be able to find those slides there along with the presentations that are being recorded today. So please check that website out for the slides. Okay, some of the questions that we have in the chat box and the question and answer. Dr. Singhal, would you use a pre-test to select only patients in high risk to develop HCC and run the screening MRI only on this selected population?
Yeah, it's a great question. And honestly, we actually have one of the grants, Joanne's actually program officer for the grant, and it's really one of the things that we're trying to move forward in terms of risk stratification. You can imagine if you were able to do so with an accurate risk stratification biomarker, we could do exactly what you're saying. You can identify those patients at the highest risk where something like an MRI would be cost effective. You can identify like an intermediate risk where you could say we could use, something like ultrasound and AFP or one of these novel biomarkers. And then, you could theoretically identify a very low risk group that you could say we don't need to do any Hcc screening at this time, and we could simply follow you with a risk stratification biomarker. Yujin Hoshida from UT Southwestern recently has developed a blood-based biomarker that appears like it may be able to help do so. It still requires validation in larger cohorts, and that's one of the things that we're doing over the next couple of years. There have also been clinical risk scores that appear to do so. I would personally caution against use of those clinical risk scores at this time, because most of those clinical risk scores have not been externally validated sufficiently to be used in clinical practice. But amazing question, and honestly very insightful in terms of where the field is going or should go. Oh, Joanne, I think you're muted.
You are right. I am muted. Sorry. The joy of Zoom calls.
Yeah.
One more question, and there are additional questions that you can check out in the question and answer box or the chat box. But what is the path to getting HCC surveillance adopted by the US PSTF so that the primary care providers more willingly participate in surveillance?
Yeah, I love this group because these are like really insightful questions and really important questions. And so this is actually really important because, you heard Hcc screening is currently recommended by professional society guidelines, but unfortunately has not been picked up by the USPSTF. I think there are some hepatologists that like to sort of shake our fist at the sky and sort of be angry about this, but I would actually argue that this is a dearth of the data that is necessary to inform USPSTF guidelines rather than a shortcoming of the actual society. So when you take a look at lung cancer screening, which I would argue has recently illustrated the path to getting USPSTF approval, there was a large trial that evaluated both benefits and harms of lung cancer screening in a large cohort of high-risk patients. And I would argue that we need to figure out a way to get those data for Hcc screening. So, there has to be a way for us to think through an innovative trial design where we can get level 1 data to evaluate both benefits and harms of Hcc screening. And I think with that in mind, I think the USPSTF would be willing to adopt this if we get the right data. I will say that I'm optimistic in part because of interest from groups like the EDRN and from the NCI in terms of giving us the opportunities to actually get those data. So while we don't have them now, I do see a path forward to getting those data over the next several years.
Thank you. Thank you very much, Amit. I just wanted to let all the speakers know that they're to check both the chat and the question and answer box for more questions. With this, I'd like to move to our next speaker, which is Dr. Anan Mehta. And Dr. Mehta is a Senior Associate Dean for Research and Smart State Endowed Chair in Proteomic Biomarkers and Professor in the Department of Cell and Molecular Pharmacology at the Medical University of South Carolina. He is focused on understanding and developing diagnostic methods and treatments for hepatocellular carcinoma. His research focuses on the development of tools for the analysis of complex carbohydrates and the discovery and validation of biomarkers for liver cancer. Dr. Mehta?
Thanks, Joanne. I'll start by thanking you and the organizers for allowing me to present to this audience. My disclosure slide is here, and I'll just point out that many of the biomarkers I'll be talking about are not approved yet as they are. So I was asked really to talk about some of the known biomarkers of HCC, what we have now, what's coming, what's really not coming, and I think where we're going and why we've sort of failed in developing a biomarker for this cancer. So right now, there are only 3 sort of approved and widely clinically used biomarkers. AFP, which was identified in the 80s, AFPL3, which is a core fucosylated glycoform of AFP, and DCP, which is now approved in the US, FDA approved and used clinically. These 3 are the components of the GLAD algorithm that Dr. Singhal just mentioned. And individually, they are hampered by relatively poor performance. So this was a study done by a large group led by the Early Detection Research Network, which looked at the performance of these 3 markers in a large cohort of patients collected all over the US. And generally what you see is an AUC of anywhere of 0.6 to 0.8 with sensitivities and specificities running about 50% sensitivity and 90% specificity. So they're good, they're not great, they're no better than ultrasound, and they're not going to really dramatically impact management when you consider that level of sensitivity in a surveillance platform is not adequate. So there's been a large search and a large desire to find new, better, more sensitive and more specific markers of liver cancer. Now, the EDRN has taken a large role in trying to develop markers for liver cancer and for all cancers. And when we think of biomarkers, biomarker development kind of goes in phases. And I'm going to be using this terminology throughout this slide. Generally, when we think of lab-based biomarkers discovered in a lab, those are phase 1 studies that are done in small cohorts of patients, really just identifying, hey, this is changing this disease or not. And when we start looking at what are called phase 2 and phase 3 studies, these are then more solid validation in well-defined populations, either at the time of diagnosis or in perspective or in retrospective longitudinal studies. Most of the biomarkers that I'm going to be talking about today are that fall into this phase, generally 1 to 3. the 4 and 5 stage biomarkers, they're not coming, or there's not as many as we'd like to have been moved to that end stage. So I'm going to talk about really 3 major classes of biomarkers: the protein-based, sugar-based biomarkers like AFPL3. I'll then talk a little bit about the DNA-based biomarkers that are coming, and then I'll briefly talk about what I think is the way forward. As Dr. Singhal just mentioned, the algorithms that are being developed now are the way forward, and they are much better than any biomarker that's going to be used individually. So this is a table that's really taken and modified from a review written by Nair Parekh in Michigan that looks at a bunch of commonly used biomarkers that are either known, like AFP and DCP, or have been proposed heavily in the literature, from things like osteopotin to midkine to glypican-3, Golgi protein 73, and so on. And most of these, as shown here, fall in the phase 2 category of biomarker development. That is, they're in the early stage. And one thing you'll notice is that for the most part, individually, these biomarkers have middling performance. That's going to be true for almost all the biomarkers we look at individually. And there's a reason for this, and we'll get to this near the end. I'm going to really focus in on just a couple of these, because if you just do a literature search on PubMed and just type in biomarker or plus HCC plus biomarker, you'll get over 3,000 papers for AFP and then various amounts for these rest. So I'm going to focus in on really a bunch of these that have the most publications, the most reports of use. Most are the most abundant ones, except for one at the very end, which is a pancreatic cancer biomarker and has lots of publications on that, but it's just been brought forward as a potential marker for liver cancer. And there's some good data with that as well. So the first marker I'll talk about is glypican-3. And glypican-3 is a well-known protein. It's a proteoglycan that's well known to be expressed on the surface of infected cells. It's a sulfated proteoglycan that's anchored to the cell through a GPI anchor. And GPI anchors tend to not be very stable. And so oftentimes they are shed into circulation. And glypican-3 is used to diagnose HCC pathologically. It can be used to stain cancer cells quite effectively. And the data now, almost 20 years old, shows that glypican-3 is highly expressed in HCC as opposed to cirrhotic tissue or normal liver tissue. And that is pretty well established now as being a tissue-specific marker. However, glypican-3's level in serum varies. And the one thing I will say about all the markers that have been mentioned, or will be mentioned, is the reports vary. So you will have multiple reports that show great biomarker performance, and you have multiple reports that show not so great biomarker performance. And that's something that has hampered this field dramatically, and I think comes down to our understanding of what we're looking at in terms of the cancer. But glypican-3, as a tissue-based marker may be good, but is hampered in its serum biomarker-based performance. GB73 is another protein that's been identified almost 20 years ago. First, again, identified in tissue as being upregulated with liver disease. Identified through glycoproteomics in a woodchuck model of hepatitis B as being upregulated in woodchucks with hepatocellular carcinoma. And this just shows the level of this protein in woodchucks without cancer and with cancer. And probably the biggest study that was done was, again, out of China, that looked primarily in hepatitis B infected individuals. And in that study, GP73 had very good performance when compared to AFP alone, showing ROCs of close to 0.9 with high sensitivity and specificities. However, GP73 has not shown good biomarker performance in the US, especially in large phase 2 studies. It is actually commercially available in China and may be a marker that's more suited for a situation where you have less inflammation, less fibrosis, less cirrhosis, a marker that's better for HBV. And the phase 3 studies are still waiting to be performed in the US to really identify the true usefulness of this biomarker alone. Osteopotin is another marker that's garnered a lot of attention as a protein biomarker. Again, this is an extracellular matrix protein that's secreted out of tissue and is found in the local tissue environment of the cancer. And the data for this marker has looked very good, showing elevated levels in cancer, in the serum of patients with cancer as compared to cirrhotics, and those with chronic hepatitis or healthies. And the sensitivities and specificities at times will look very good, with high sensitivities and okay specificities, in some cases very good. But again, this is a single study. There are other studies that show much poorer performance. And we're still, of course, waiting to see this marker brought forward either alone or in combination as a biomarker that's clinically useful for HCC detection. One protein I'll just mention briefly is this liver-secreted serine protease inhibitor CASL, it's our SPIC, S-P-I-K. This is a protein that's involved, it was first identified as being associated with pancreatic cancer. Its function is a protease inhibitor. It has been shown to be found by a group in Doylestown as having a liver-specific form that's upregulated specifically in liver cancer, and they developed an assay for this that detects specifically this liver form shown here. And in their large studies they've done, about 500 patients, all at the time of cancer detection, a cross-sectional phase 2 study, they're seeing sensitivities and specificities substantially greater than AFP alone in these cohorts. So this is another promising biomarker that may hopefully come forth that can be used in combination with others to help identify liver cancer. Another class of cancers, another class of biomarkers that's shown some promise in liver cancer are glycan biomarkers. Glycans are something I do, and I find them useful because one thing we know is that when glycans change on cells, on tumor cells, those glycans are directly impacted by the genetics of the tumor. So activation of the beta-catenin Wnt pathway will cause different glycans to be expressed. Modifications in TERT will cause different glycans to be expressed. And the same machinery that puts on glycans on the cell surface of that tissue, of that cancer, will cause those glycans to be secreted and be seen in the circulation. So we can go easily from tissue to circulation. And we've developed novel methods in our own lab to identify glycans in situ. The way this works is we take a piece of tissue that to a pathologist looks like, a cancer surrounded by adjacent fibrotic tissue, but to a mass spectrometer, it just looks like spots that where I can fire a laser to measure analytes. And the way it works is simply this: if we have a piece of tissue shown here on the left, the cancer is here in the middle. We can do mass spectrometry, look at it, ask the computer what are the sugars that are on glycoproteins found outside of the tumor and what's found in the tumor, and then what's in the tumor, and you can see clear identification of glycans that are found in the tumor. So we know exactly what's occurring in the tumor. And you can then look at those, and the p-values are quite good. They're all variations of a similar structure shown here. A core fucosylated glycan with different levels of branching that are found directly in cancer tissue. This is important because this is, for the most part, the same type of sugar structure found on AFPL3. So AFPL3 is the core fucosylated version of AFP. It's been known for years, first used in Japan, now brought to the US and part of the GLAD algorithm. We alone, the marker is not good. Its sensitivity and specificity are generally poor, still about 40 to 50% sensitive with a certain level of specificity. I would also mention that AFPL3 technically is a bit more difficult to measure alone. It requires special machinery, but it works. We, in our own lab, we've used proteomics and glycoproteomics to identify other proteins that contain that sugar modification in serum. And one of these proteins is fucosylated kininogen. And like AFP, it is upregulated in cancer in the serum of patients. But again, like AFP, does not make a great marker. Its performance is actually lower than AFP as a single marker. But when used in combination with AFP as an algorithm, including age and gender, gives you much better biomarker performance. And that's the common theme you're going to hear over and over again, is that alone, most biomarkers are suboptimal, but when used in combination with other factors, will give you the performance that I believe can lead to real clinical utilization. So I'd like to end by talking a little bit about the genomic markers that are coming out. There have now been lots of publications looking at the genetics of HCC, the genomics of HCC, the transcriptomics of HCC. I'll just talk briefly about some of the ones that have looked at circulating cell-free DNA in patients. You know, this was a study that came out in Clinical Cancer Research in 2019. So in roughly almost all patients they examined had some level of altered DNA available in the circulation. That's important because that gives you what's going to be the true sensitivity of this marker. The genetic mutations were varied. There are lots of mutations that you can find in patients with liver cancer in the circulation. So there are a lot of genomic changes. Almost all patients have them, but there's lots of heterogeneity. And that's going to be sort of the challenge in how we develop markers that are able to cover all of the genetic heterogeneity we see in HCC. And that's why I believe that these single-use markers or single markers have never really worked, because they're trying to identify a wide variety of different cancers that we call HCC. Just recently, this was the first paper that came out from basically the Exact Sciences group. This is from Chalasani in Indiana, and they've identified 3 methylated DNA markers, homeobox proteins, a testis-specific protein, another homeobox protein, along with a genomic marker, beta-3 gal-T6, a gal-transferase. These together, along with age, gender, and AFP, age and AFP, make a very good diagnostic algorithm that has shown great promise. I'm not going to talk about the algorithm. I'm just going to let that, I think, go to the next speaker. But again, multiple markers used in combination, genomic markers, methylated markers, protein markers, and clinical factors together are what's going to give us the biomarker that we need clinically. There's another use, so biomarkers of genomic biomarkers can be found both in the blood of patients with liver cancer. They can also be found in the urine of patients with liver cancer. And this is unpublished data from a company in Doylestown that I'm not associated with called JBS Life Sciences. They've actually shown that you can find both circulating DNA that's found in the urine. This is a p53 mutant, p53 mutation, as well as two other genes that you can find in the urine of patients with liver cancer. An assay like this would be potentially useful in a low resource setting like Africa, for example. And so you can get good performance when you combine AFP with these markers and increase sensitivity detection alone from 60% all the way up to 85% for early stage cancers. And so these markers can be found in serum and in urine and other non-invasive sources. So there's great value in that. And lastly, I'd just like to point out my key point, and that is that, you know, we're never going to be able to find a marker, a single marker for just HCC. And that really comes from work that really, you know, Eugene Oshida kind of pushed early on in 2009, 2010. And if you look at the large genomic paper that came out in Cell by Lewis Roberts, we now know that HCC is a very heterogeneous, genetically heterogeneous disease, that one cancer is not all the same. And I've said this before, and I'll say it again, AFP is a great marker for AFP positive tumors. Not all tumors genetically express AFP, but AFP is good at identifying a subset of cancers. We ourselves have found that our fucosidase markers, and AFPL3, for example, is found predominantly in these S1 tumors. So there is no biomarker, single biomarker, that's going to identify all these different subclasses of cancers. They're going to have to be a mixed group of biomarkers, genetic, proteomic, glycomic, and clinical factors that together will give us a diagnostic algorithm that'll help identify those patients with liver cancer. So with that, I'll just give my conclusion, and I've kind of stated my feelings and my opinions quite, I think, strongly, I believe. And I think that going forward, we are now at an area where I think in the next 3 to 5 years, we're hopefully going to see some of these biomarkers come to fruition. I know the genomic markers are coming forward very strongly. They're showing great promise. The GLAD algorithms that include gender, age, AFP-L3, AFP, and DCP, as Dr. Singhal showed, look very good. We know a lot of them come from the tumor, so that's even better. And so they're together as part of an algorithm, look very good. I think from a discovery point of view that we really do need to look at these biomarkers in the context of the genetics of the cancer. I think it's very important to do for both our discovery and our validation to identify what we're actually identifying in terms of the genetics of that HCC. And this is just my acknowledgement slide. I, again, work with many people. And I'll just also like to thank all the people that have given us Serum. I'm a biomarker guy. We do a lot of biomarker discovery, a lot of biomarker validation, and none of what we do would ever be possible without the patients that have given of themselves physically to allow us to do our discovery and our research. And with that, I thank them. And with that, I thank you, and we'll stop my screen share and take any questions.
Thank you very much, Dr. Mehta. I'm going to take the moderator's prerogative and ask the first question. And because we're running a little behind, this is going to be the only question. My question is, do you envision different panels of biomarkers for different liver cirrhosis etiologies, for example, alcoholic liver disease or NAFLD or viral hepatitis?
I do think you'll get algorithms that are tweaked in some ways that are suited for different etiologies. Because, I will say from our own studies, in the past, HCV, HBV type of liver cancer, in some ways they were different than what we're seeing now with the new NASH cohorts of patients that have, very well-defined liver disease, very low, inflammatory markers and such. So I do think that you'll see algorithms that are tweaked for specific groups. I could see that.
Okay, thank you. And then again, I want to remind the speakers to please check the Q&A in the chat box as well. Our next speaker is Dr. Nabiha Tayyab, and she's a member of the faculty at the Department of Data Sciences at the Dana-Farber Cancer Institute. And Dr. Tayyab collaborates widely in cancer research field in general, and her current methodological research interests focus on developing statistical methods when evaluating biomarkers for detecting cancer in a two-stage study design with early termination for futility, and developing screening algorithms using multiple longitudinal biomarker measurements for early detection of liver cancer in high-risk populations. Dr. Tayyab?
Thanks, Joanne. Thank you to you, John and Betsy, for the invitation to present today and tell everyone a little bit about my work, which is hopefully building on what we've been talking about in the past presentations. And so I'm going to go ahead and share my screen. And so today I'm going to be talking about algorithms. And our goal of algorithms is to take these biomarkers that have potential and extract further information from them to further improve their performance. And so once you have a validated biomarker, one of our goals is looking at the trajectories of those biomarkers to develop personalized screening algorithms that can further improve the performance. And getting at that heterogeneity that Dr. Mehta was talking about, you also have heterogeneity for these biomarkers across patient populations. So some of the previous, sorry about that. So most of the studies that have been talked about so far, you're only thinking about biomarkers, and in particular, I'm talking here about AFP because that's the one that we have the most data on at a single time point. So you're not thinking about what is the AFP trajectory in patients. You're just saying when we're evaluating AFP, we're looking at it at a single time point, a snapshot. There has been some work using regression models. Thinking about incorporating the change in AFP, so the trajectory of AFP. The one that I've been working on with the collaborators at Dr. El-Sarrag at Houston Baylor is a HES algorithm that takes your current AFP, your change in AFP over the last year, incorporates some of the clinical factors such as age, ALT, and platelets, as well as etiology. Actually, that was a recent update we did to the algorithm, and comes up with that approach for improving early detection of HCC. However, I would say one of the reasons why I've been working on statistical methods is because regression models have limitations, especially when we're thinking about these patients that are under surveillance for very long periods of time. We actually have a lot more data on them than what we can put into a regression model. And so here, what I'll be talking about is these screening algorithms that have originally been developed for ovarian cancer screening, and how can we translate them and further improve them for the setting of early detection of HCC. And so the first algorithm I'm going to talk about is called a parametric empirical Bayes algorithm, PEB for short. Essentially, when we have a single biomarker, what we're doing with this PEB algorithm is we're defining a personalized threshold for every patient. So once you enter screening, once we have some data on you, we can actually come up with a threshold. So instead of like a common threshold for AFP is 20 nanograms per milliliter, instead of using the same threshold for everyone that's undergoing surveillance, once you have a little bit of information on that patient, just a single prior value, you can actually define a personalized threshold for that patient. And what we're doing is we're looking for deviations. So here's an example patient. This is 4 years prior to their diagnosis of HCC. We have AFP collected on them. When you don't have any screening history on the patient, the threshold is the same. So this is that blue line, that fixed threshold. However, now at this next visit, we actually have this prior screening information and we can derive a personalized threshold for this patient. And you can see, because they actually seem to have lower AFP levels than the other people in their target screening population, they actually have a lower threshold. It takes that into account. And you can see here at every time point, we readjust that threshold based on all the screening history we have in that patient to date. And so at 1 year prior to their HCC diagnosis, this patient crosses their individual threshold. So what we are identifying, as you can see, is the subtle increase in AFP that we are observing. This algorithm allows us to pick that up. They have not yet crossed that fixed threshold, but they have crossed their own personalized threshold. And you can see that they actually only cross their fixed threshold at their time of diagnosis. So the AFP increases very subtly, and then it just shoots up right at the end. And so that's the advantage of these algorithms, is that it allows you to do this. The mechanism behind it, I'm not going to go into too much detail, but essentially what we're doing at each point is, from a statistical perspective, we're asking, has this patient had a deviation in their biomarker trajectory? And was this deviation statistically significant? And in order to do that, we need to know how the biomarkers perform in patients who are at risk but have not actually developed the cancer. So in this case, we've focused a lot on cirrhosis patients. And so we want to know, in patients with cirrhosis, what is the variability within a patient? What is the variability between patients? And what are the kind of population averages of AFP we're seeing? And one of the advantages of the PEB algorithm is, at this point, it actually only, for a single biomarker, you're not using any, you don't require data on the patients, this longitudinal data on patients who developed HCC. You just need longitudinal data on patients who are at risk for developing HCC. And those are easier data to obtain. So what we do then is, once we have these model parameters, we can get, and we have the patient screening history, we can get an estimate of the mean AFP level for that patient. And then, instead of comparing it to a fixed threshold, we can compare it to an individually tailored threshold that then looks for a significant increase. And you can see, so here we applied this to a data from the Hcc trial. And in this study, just a single biomarker, AFP only, if we look at it at a single time point and we ignore the history of the patient, the sensitivity at a 10% false positive rate is 60.4. We can boost that to 77.1 by incorporating the data that we already have on these patients, their screening, their trajectory of AFP. So based on those promising results, and also like what Dr. Mehta was saying, we looked at, okay, a single biomarker is not going to capture all the heterogeneity of this population of patients who develop HCC. So this is an example of an AFP negative patient in the Hcc trial. You can see pretty much the AFP remains stable, but DCP, the other biomarker in the GALAD panel, actually did increase prior to onset of HCC diagnosis. So what we have developed is a screening algorithm that uses not as just the trajectory of a single biomarker, but the trajectory of multiple biomarkers. And here what we're doing is now we're saying, for every patient, every time they come into screening, we calculate what is their risk of HCC, given everything we know about them and everything we've collected on them to date. So we have, let's say we have this longitudinal trajectories for multiple biomarkers. Maybe we can even incorporate clinical information here, other kinds of patient information. What is we can then use statistical models to get an estimate of what we call the posterior risk. So given what's the probability that they have HCC, given everything we know about the patient, and the probability that they don't have HCC, given everything they know. And in order to do that, what we need is we use the Bayes rule. I won't go into too much of detail about this, but essentially for the second component, for this first component, what we need to be able to do is understand when we get to multiple biomarkers, we do actually need to understand the trajectory of these biomarkers when they have HCC. And so this is what we call a fully Bayesian algorithm. And so we make similar assumptions for those patients with who don't have HCC and don't develop HCC in terms of what their biomarker looks like. In general, we see with a lot of these biomarkers stable trajectories that vary over time. And then in patients who do develop HCC, we see some patients like the AFP the patient I showed you before, the AFP is not really changing. They just have the stable trajectory. But for their DCP, we have this change point. At some point, their DCP starts increasing. So by being able to collect data on these patients, estimate these models, we can then derive posterior risk calculations that combine the longitudinal trajectories of multiple biomarkers. And here's just an example from the Hcc trial. You can see that for this solid black line, the top curve is when we apply this fully Bayesian algorithm to both AFP and DCP. Now we've boosted the performance to 89.5%. So we're using data that we've already collected. We have it there. We're just using statistical models and the trajectory of these biomarkers to get more information. And so the next steps are we need to validate these. So this has so far been just initial studies. And so as Dr. Singhal mentioned, we have the Hepatocellular Early Detection Strategy study, the HEAD study that is matured now, and we're going to be applying our algorithms in this study. We also have the Texas Hepatocellular Carcinoma Consortium, and I have collaborations with those investigators. And that will be another very large cohort study where we can really understand how these algorithms will perform in validation studies. The key with all of these algorithms, I've just kind of given you a brief introduction, but we're not only, the other aspect of it is we can incorporate clinical information. So these biomarkers are not only important for, they're not only affected by the HCC, they are potentially also affected by the cirrhosis of the patient. And so if we can incorporate clinical information that can explain the variability of the biomarkers that are related to their liver disease, but not the development of HCC, we can then have a cleaner signal in these biomarkers for the onset of HCC. We also have a changing landscape of cirrhosis. And so as was discussed, with these different etiologies and the changing etiologies, longitudinal blood-based biomarkers are going to become potentially an avenue of more accessible surveillance. And so boosting the performance of these would, in this changing landscape, would be of great interest. The challenge, though, is implementation in clinical practice, and the requirement that you are good, especially the more data you add, it means the more data you do need to have and collect. And so that's the balance. Like, how much of data do you actually need to be able to get a good boost, but still maintaining a practical approach that can actually be applied in practice. And maybe in high resource settings, you can integrate it into the EHR. In more low resource settings, that is an open question. So just to end, I want to thank, so my research as a biostatistician, I am very grateful to all my clinical collaborators for their, they provide me access to their data and their clinical perspectives. My statistical collaborators, who work on the methodology with me, and the NCI fund for providing funding for this research. Thank you.
Thank you, Dr. Tayyab, for your presentation. I just want to make everyone aware that this webinar is going to extend beyond 5 o'clock till about 5:15. We have 5 excellent speakers, and 20 minutes doesn't seem to be enough for these plus questions and answers. So once Dr. Chung finishes his presentation, we'll have a couple questions, and then we will open it up. We have 2 excellent discussants, Dr. Anna Locke and Dr. Lewis Roberts, and we would also like to give them the opportunity to chime in on this webinar. So, okay, with that, Dr. Tayyab, question for you here. Can you stratify patients based on the current biomarkers and identify patients that are at higher risk and therefore tailor their surveillance for HCC? You know, certain patients will go for imaging, others can be, just followed by blood markers.
Yeah, I think that's like Dr. Singhal mentioned, that would be the overall goal. Like you would think about it in different phases. Like you would have a risk stratification approach where you're thinking about who's the highest risk patients and how much of resource do I want to put into surveillance in those populations. And then I think that was kind of getting what I was saying at, like these algorithms that are potentially a little bit more resource intensive, but you get a lot of improvement in sensitivity of these algorithms would be tailored to that population. And then also one of the challenges is that, you know, when you have a very high incidence of in a particular subgroup, you don't need your biomarkers to be as good. Like, you know, there's different categories of biomarkers. And so if you have maybe a low risk population, you need a very, very good biomarker. If you have a high risk population, maybe you don't need as good a biomarker. And so I think that is the key, that a tailored strategy, not only within like what I was speaking about the context of the algorithms itself, but a tailored strategy from this even entering into surveillance all the way through surveillance would be the optimal approach for a cost-effective surveillance, HCC surveillance.
Thank you. Thank you very much. We'd like to now turn to our final speaker for today. And this is Dr. Raymond Chung. And Dr. Chung is Director of the Hepatology and Liver Center, Vice Chief of Gastroenterology, and the Kevin Polly Marconi Research Scholar at the Massachusetts General Hospital. He is also Professor of Medicine at the Harvard Medical School, and he has been internationally recognized as one of the leaders in the areas of virology, pathogenesis, including hepatocarcinogenesis in the HCV research field. And his laboratory is also conducting work on chemopreventative strategies for liver cancer in patients with chronic liver disease. Dr. Chung?
Thank you very much, Joanne, and I'd like to also thank the organizers, John and Betsy, for putting together this this outstanding symposium. Let me share my screen for a moment here. Is that projecting?
Yep, that's great.
Okay, terrific. All right.
It's
Again,
just a
so
little off screen, I believe. You can't see the full title.
Oh, yeah, yeah.
that, is that better?
The edges are cut off, Ray.
Oh,
It says RAL hypertype. Yeah, so all the,
does this work?
no, still cut off.
Oh,
Would you like me to share?
Yeah, why don't you share then?
Will do.
Sorry, I'm not sure what happened.
There you go.
Oh, okay, great, terrific. Why don't we go to the next slide? These are my disclosures. I wanted to spend these next 20 minutes or so covering viral hepatitis and HCC risk driven by viral hepatitis principally, and to really look at drivers through a variety of models, including preclinical animal models and human models as well. And I'd like to conclude with a consideration of markers of HCC risk. We've talked about HCC markers themselves, but I'd like to spend more time considering identifying patients who are at higher risk for HCC as the focus of this talk. So this slide demonstrates, of course, what we have heard from all of our speakers today, that viral hepatitis is a prime mover for HCC. Chronic Hep B, of course, in two forms, those with cirrhosis at a high annual risk of HCC, and even those who are inactive carriers carrying an increased risk compared to uninfected persons. Replicative HBV also appears to be an increased risk compared to those who are not actively replicating. In chronic Hep C, advanced fibrosis or cirrhosis appears to be the prerequisite, with anywhere from a 1 to 4% annual risk of development of HCC in cirrhotic patients. Next slide. So again, mechanisms of viral hepatocarcinogenesis, insights from animal-human studies of HBV and HCV driven HCC. We'll consider briefly genetic and epigenetic contributions, and really dive into some gene expression-based biomarkers for HCC risk. Next slide. So let's start with hepatitis B. Hep B is a very compact genome, a partially double-stranded DNA virus with 4 overlapping open reading frames, as shown on this cartoon, with 4 major gene products: the surface glycoprotein, the polymerase, the pre-core core gene product, and then the 4th aptly named X protein, which is really in many ways critical for driving growth and hepatocellular carcinoma risk in chronic Hep B infection. Next slide. So as we think about the viral life cycle, I want to point out one major aspect of the life cycle of Hep B, and that is its predilection for movement directly into the nucleus of the infected hepatocyte. So it sets up shop both as a stable covalent closed circular or cccDNA form, which is episomal in nature, and is then transcribed and translated into the viral products that make up mature virions, but also is integrated into the host genetic material as well. And this is an important point to make, and when we think about viral hepatocarcinogenesis related to Hep B, as we'll discuss. Next slide. When we think about carcinogenesis, we think about Hep B causing HCC directly, and we think about that through integration. And with that integration, insertional mutagenesis, insofar as an unfavorable insertion into neighboring sites that may encode for proto-oncogenes and lead to fusion proteins that promote growth. So too can it also unfavorably integrate into regions that abut tumor suppressor genes and inactivate those TSGs, again increasing risk for cancer development. It also activates telomerase reverse transcriptase, which leads to elongation of the telomere and really an increased immortality of the cell and reduced sensitivity to senescence. All of these factors can again promote abnormal growth. So too does the X protein itself act as a transcriptional activator. So when expressed, it can promote intracellular calcium fluxes, signal through protein tyrosine kinases like PIK2, SRC, RAS, RAF, and MAP kinase, all well-known growth-related kinases, and lead to a broad upregulation of growth control genes. So too, as well, it inactivates tumor suppressor proteins such as P53. Next slide. But and we have certainly been enlightened by transgenic mouse models of hepatitis B. The first models essentially involved overexpression of individual viral proteins, the best example of which was overexpression of surface antigen, or the HBV large envelope protein, which produced strikingly hepatocellular injury, regenerative hyperplasia, a picture of chronic inflammation and oxidative stress, together with oxidative DNA damage, and ultimately transcriptional deregulation and the development of HCC in a high frequency of animals. However, this early model was critiqued by virtue of the fact that it was a non-physiologic excess of a toxic viral protein. However, other studies subsequently done by investigators in Japan demonstrated that hepatitis B X protein, also expressed in transgenic mice, also produced the phenotype of HCC in a very large proportion of animals. 84% of these mice developed HCC by 24 months. Next slide. But so too are there indirect effects. And these indirect effects are really mediated by the host response to the virus itself, insofar as the introduction of an immune response to Hep B induces a picture of chronic injury, inflammation, and repair that repeats itself over and over during chronic infection. And so that was demonstrated subsequently in an HB surface antigen transgenic mouse under the albumin promoter, but in this case, expressed at much lower levels than demonstrated in the first study I shared with you. And this model was then adoptively marrow transferred, the marrow of immunized non-transgenic donors that had been immunized against Hep B surface antigen. These mice, the recipients then developed an ALT rise, surface antigen fall, and strikingly, HCC in nearly all animals, compared to none of the transgenic mice receiving unimmunized marrow transfers. Next slide. So these data then point to the notion that they're both direct and indirect contributors in Hep B to hepatocarcinogenesis. Hep C is a very different beast. Despite the fact that it infects the liver, that's about where the similarity with Hep B ends. This is an RNA virus that relies entirely, next slide, on a replication outside of the nucleus for its existence. You'll note here that the nucleus is untouched in the HCV life cycle because there is no DNA intermediate and no integration or latent form of Hep C nucleic acid. Rather, again, there is continuous replication taking place in the cytoplasm. So this virus must replicate or perish. Next slide. So when we look at the reasons why hepatitis C may induce hepatocellular carcinoma, they clearly must differ at some level because of the lack of integration into host genetic material and lack of a stable latent form. We've been informed again here by mouse models, for instance, an HCV core protein transgenic model, in a striking example from Japan, developed steatosis and in up to a third of animals hepatocellular carcinoma. Indeed, the core protein appears to inhibit microsomal triglyceride transfer protein, inhibits VLDL secretion producing steatosis, which in turn promotes the development of reactive oxygen species and oxidative stress. This is further corroborated in cell lines in which HCV core protein induces mitochondrial injury. Those same oxidative species induces compensatory antioxidant gene expression and mitochondrial and nuclear DNA damage. Together with non-structural proteins in culture, there is also an enhancement of NF-kappa B and a survival signal, an induction of anti-apoptotic genes. So together, each of these can contribute to hepatocarcinogenesis. In culture, it should also be added a tissue culture that HCV replicative virus also induces oxidative stress through reactive oxygen species. Next slide. So together, one could potentially present a unified field theory, if you will, for viral HCC by showing that viral protein expression, so for instance, HCV core and non-structural proteins promote reactive oxygen species and enhance anti-apoptotic genetic programs. Hep B itself, again, is responsible potentially for genomic instability, integration events, and trans-activation events in producing HCC. Together, Hep B and Hep C collectively induce immune responses, which in turn further ramp up oxidative stress and again promote a picture of HCC through genotoxic DNA damage. Together, this is further augmented through cofactors like iron overload and alcohol, and even the metabolic stress of non-alcoholic fatty liver disease, all again contributing to further oxidative stress and perhaps cooperative interactions in promoting HCC even further. Next slide. So to corroborate this and the idea that HCC is a very different beast from other cancers such as colorectal cancer, which experience a very discrete sequential pattern of genetic alterations, the mutations in human HCC has been alluded to earlier in earlier talks. They're frequent, they're heterogeneous, and they're genome-wide. So oncogenes such as those listed here and tumor suppressor genes all have found mutations in human HCC, including loss of heterozygosity in a number of chromosomes. Speaking to the idea that oxidative stress is leading to stochastic DNA damage and the accumulation of mutations that then exceed a threshold and produce malignant clones. Should be noted here that the Wnt beta-catenin signaling pathway is itself disrupted or regulated by HCV proteins like HCV core, and the EGF pathway, again, a driver of hepatocarcinogenesis, drives EGF signaling as well as hijacking the EGF receptor for its own entry as a virus into the hepatocyte. Next slide. So what has been noted already by other speakers is that we've got viruses that are treatable, that are curable, that are controllable. Most noteworthy, of course, in hepatitis C is the introduction of curative direct-acting antiviral regimens, which reduce HCC risk by about 70% in patients with cirrhosis. And I think as Amit pointed out in his talk, this absolutely means that there is still a persistent risk, albeit markedly reduced. And so screening for HCC remains essential after HCV cure in patients who harbor advanced fibrosis. We have seen, and so we can ask reasonably, what is responsible for that persistent risk in a virus that does not have any integrated genetic material? So there could be genetic changes despite not having insertional mutagenesis. These genotoxic stresses like inflammation and oxidative stress we have spoken to may still linger to some extent. Virus-induced proliferative and anti-apoptotic signaling through a number of pathways is listed here, including EGF and Wnt. Virus-altered signaling circuits of differentiation and angiogenesis also exist, including the Notch and VEGF pathways, which are altered by Hep C itself. And the impact of cofactors cannot be overstated, including steatosis, fatty liver disease, alcohol abuse, iron excess, and co-infection with hepatitis B. But I wanted to point out that there are emerging data to support the idea that HCV also leaves a footprint or scar in the form of epigenetic changes that appear to linger. Next slide. And so a reasonable hypothesis here is that there are epigenetic changes, modifications of histones that are induced that lead to altered gene expression as a result of enhanced access of transcriptional machinery to genetic material, in this case DNA. And these changes may persist long after removal of the underlying viral infection and lead to continued risk for HCC. Next slide. And a number of studies have addressed this, including a study here which performed chromatin immunoprecipitation and sequencing of DNA bound to chromatin, known as ChIP-seq, in which histone modifications, specifically acetylation of a histone, the third histone, or H3, which is known to be a permissive change that enhances transcription, was analyzed across the genome in uninfected HCV infected and DAA cured individuals. Next slide. And one can see here that in looking at these genes shown here in columns, that there is a clear difference in the histone acetylation of those patients with more advanced forms of fibrosis, shown here on the right half of the panel among HCV infected persons, compared to those with lesser degrees of fibrosis. Next slide. Moreover, in those patients who are cured, those histone acetylated changes appear to be partially reversed, but in those with early liver disease, namely F2 or F3 fibrosis, but in those with F4 fibrosis or cirrhosis, next slide, those changes are really not reversed, supporting this idea that epigenetic scars are being left in the context of chronic infection, particularly in those with advanced fibrosis. So these epigenetic genes changes, next slide, appear also to drive a number of relevant genes, including those cancer risk genes shown here in this slide. These include, I might add, the EGF pathway, which itself, as I've noted, is altered and regulated by Hep C itself. So these alterations appear to persist after cure. Next slide. So what tools can we bring to bear to stratify those at future risk of HCC? Based on what we know about genetic alterations and gene expression changes, can we in fact leverage findings to develop tools? Next slide. And to this end, I want to highlight studies by collaborators, Eugene Hoshida at UT Southwestern, whose work was alluded to by Dr. Mehta, who started with essentially the premise that gene expression changes or transcriptomics can really tell us not just about those at risk, but really reveal driver pathways for hepatocarcinogenesis in a given tissue or set of tissues. And so what he and his colleagues sought to do was to essentially take an unbiased approach toward characterizing messenger RNAs from a large set of liver tissue and HCCs from patients who had been resected for HCC and to determine their future risk for recurrence. That was the original iteration, and a microarray study was done, and essentially after informatic analysis, 186 genes, some of which were considered high risk, shown here in red, low risk, shown here in blue, were associated with a poor prognosis, that is to say, a high risk for the development of future HCCs and even death. This 186 prognostic liver signature, known as PLS, was actually found not from the HCC tissue itself, but from neighboring cirrhotic liver tissue. And this was performed on archived, formalin fixed paraffin embedded tissue. So really, it was a technological marvel to be able to do this, but to really identify that the risk involved can be identified not in the tumor itself, but in the underlying substrate or fertile field, the field defect that gives rise to HCC among cirrhotic patients. Subsequent studies from Eugene in conjunction with collaborators like ourselves and others demonstrated the predictive value of this prognostic liver signature for de novo or first-time HCCs, as well as the risk for decompensation of HCV-related liver disease, that is to say, liver fibrosis progression, which underscores the point that fibrosis progression and HCC are intimately intertwined events. Next slide. So indeed, the question I think could then be asked whether HCV itself induces the prognostic liver signature, and studies in our lab performed by Jacinta Holmes revealed that HCV itself, a replicating tissue culture competent model of infectious Hep C, indeed induces that same prognostic liver signature compared to control or mock infected hepatocyte-derived cell lines. So with this in mind, that HCV induces the PLS, and further data that antiviral therapy in culture can suppress the signature, the question was then asked, could we learn something about that persistent risk in persons who had undergone curative antiviral therapy for Hep C, but yet still developed HCC? So the right panel demonstrates paired liver biopsies from patients before and after curative antiviral therapy, or non-curative in this case. They're both sustained responders and non-responders receiving interferon-based therapy, and who had undergone serial biopsies, some of whom went on to develop HCC and some of whom did not. There were a total of 34 of these paired biopsies. And what you can see here is that the high-risk genes are shown here to be downregulated here in the orange to variable extents, and the low-risk genes upregulated to variable extents after treatment. But you will note here that those sustained responders who did not have HCC had a more profound suppression of the signature of the high-risk signature, and upregulation of the low-risk dimension of the signature in those who did not develop HCC compared to those who went on to develop HCC, suggesting that the signature itself is less completely reversed in those who go on to develop HCC, suggesting again that this risk signature is an indicator for subsequent future risk, even in persons who are cured of their viral infection. Next slide. So another very important point that was made in subsequent studies by Eugen's group was that this is not just confined to viral hepatitis. So Hep C and Hep B, to be sure, both produce prognostic liver signatures, and the risk of HCC appears to be linked to those prognostic signatures, but so too was that true for other etiologies, including alcohol, fatty liver, and fatty liver in conjunction with hepatitis. And you can see here that low, intermediate, and high risk scores for the aggregate group predicted subsequent HCC risk development here in the upper right. And in the lower right, one can see here that in terms of a hazard ratio of HCC development, all of them were to the right of a log scale of 0, namely 1-fold, for each of the etiologies that I've just described. So the prognostic liver signature appears to reflect a final common pathway and is pan-etiologic for all forms of chronic liver disease that would increase risk for HCC. Next slide. So another approach that Eugen and his colleagues took was to perform a agnostic regulatory gene module evaluation. In this case, over 500 liver tissues of patients with cirrhosis of a variety of different etiologies listed here was performed, and network analysis was performed. And you can see here a lot of familiar pathways emerging again. EGF, the Wnt signaling pathway, IL-6, pro-inflammatory, Rho-A kinase, YAP and CTGF downstream actors in the Hippo signaling pathway, all of which have been implicated in HCC, not just virally mediated, but also non-virally mediated HCC. And so this network analysis is capable of identifying key driver gene candidates. And interestingly enough, these regulatory modules consistently appear across a whole variety of HCC animal models, whether they be chemical animal models, obstructive in the form of bile duct ligation, diet-induced models like high-fat diet or the methionine choline deficient diet, and even genetic models of HCC, all appear to consistently produce these regulatory gene modules that appear to drive HCC. Next slide. And further informatic analysis identified some of the most important driver genes shown here, including LPAR1, which is a receptor for lysophosphatidc acid, or LPA. Now, the LPA lysophospholipid pathway has been implicated in hepatic fibrosis and cancer, in fact, in fibrosis in a variety of different organ systems. And it should be also noted that LPA receptor 2 and ACAP13 are both part of the high-risk 186 gene PLS and lie downstream of LPA signaling. Very important to point out as well that Hep B and Hep C each induce autotaxin, which is a key protein which converts lysophosphatidylcholine into LPA, which in turn signals through its receptors. And LPA antagonists reverse the high-risk signature in ex vivo cultures of fibrotic liver tissue that harbor the high-risk signature. So there's data emerging from these analyses that LPA signaling acts as a central pathway for HCC. Next slide.
Dr. Chung, this is Joanne Renato. We're getting up at the top of the hour, so I don't know how many slides you have. I'd like to give the opportunity for some of the discussants as well to chime in.
Okay, and so I'll close with a consideration of the fact that the PLS is associated potentially, and this is a biopsy-based signature, and the question, of course, then can a circulating test, a more tractable test, be developed? Eugene and his colleagues have subsequently developed a serum protein-based assay known as the PL-seq assay of 8 secreted markers. And again, appear to perform very well in terms of predicting incident HCC with a high hazard ratio of 3, and even incident HCC after sustained response for a cure of Hep C with an adjusted hazard ratio of 3.8. Next slide. And so this gets into the question of, can we chemo prevent HCC? We would want to identify persons at higher risk. A number of studies have suggested, including studies from our group, that statins and aspirin are associated with a decreased risk of HCC in population studies, including lipophilic statins and aspirin in the doses shown here on this slide. And in particular, lipophilic statins, like atorvastatin or simvastatin, can modulate the prognostic liver signature in vitro and are known to have effects on both LPA and HIPPO signaling drivers of hepatocarcinogenesis identified in these studies. Next slide, and I'll move to the summary, in which basically HBV and HCV are major drivers of HCC. DAAs and suppressive antiviral therapy reduce but do not eliminate the risk for HCC. And there are multiple mechanisms for this persistent risk, including direct viral protein effects, as well as indirect effects provoked by inflammation, including the pathways demonstrated here. And it's important to note that expression signatures in viral hepatitis, as well as chronic liver disease of all stripes, are predictive of HCC and suggest targets for blockade. Surveillance should continue for advanced fibrotic patients, even with cure and control of virus, and that stratification and chemoprevention for high-risk patients may be possible. And we are embarking on an NCI-funded trial of atorvastatin for modulation of the high-risk PLS. Thank you for your attention. And I think the next slide just thanks everyone involved.
Thank you, Dr. Chung. Appreciate your presentation. Now I would like to open it up to the discussants. Our 2 discussants are Dr. Lewis Roberts, who is the Peter and Francis Georgeson Professor in Gastroenterology, Cancer Research, Consultant Gastroenterology and Hepatology at the Mayo Clinic. And his research focuses on the molecular mechanisms of liver and biliary carcinogenesis, as well as biomarkers for the diagnosis of liver and bile duct cancers. And then Dr. Anna Locke, who is the Alice Lorman Andrews Research Professor in Hepatology in the Department of Internal Medicine at the Michigan Medicine in Ann Arbor, and also the Director of Clinical Hepatology and Assistant Dean for Clinical Research in the University of Michigan Medical School. And her research focuses on the natural history and treatment of hepatitis B and C and the prevention of liver cancer. So Dr. Locke and Dr. Roberts.
Okay, so I'm going to start first. So first of all, I really appreciate the organization of this meeting, because it brings the different topics together, and it talks really excellent. So clearly, HCC is a major problem, and we used to think that it is a major problem in Asia and Africa, but everyone now recognizes that this is a major problem in Western countries, including the US, and it's rising. But what is very exciting, and we heard from the various speakers, is that the epidemiology is changing. For many years, it's mostly viral related, but with the availability of antiviral therapy, and certainly with hepatitis B vaccination as well, viral etiology is going to be of diminishing role. We already see a drop in Asian countries, and that's really related to prevention and treatment of hepatitis B. And with hepatitis C, although we're not seeing a big drop yet, we expect that with DAA therapy, in particular treating patients early, preventing cirrhosis is important. And we've just heard from Ray Chung that once patients get to cirrhosis, once they have been infected for a long time, that risk of HCC persists after SVR. I think there are a number of questions that remain unknown. Just like with hepatitis B, the first few years, people were a little skeptical how effective is antiviral therapy in preventing cancer, because not surprisingly, the cancer incidence remained very high for the first few years, because the antiviral therapy is not cancer therapeutics. And so a lot of the early cancers were already there at the time treatment was started. But we're beginning to see with hepatitis B, after the first 5 years of antiviral therapy, the incidence start dropping. So for Hep C, my question is always in the patients with cirrhosis. Yeah, we know that we need to continue to do Hcc surveillance, but for how long? Is it lifelong, or is it for the first 10 years? And then after that, the incidence drops below a rate that we can stop doing surveillance. And these are the things that we don't know. And of course, NAFO now plays a much more important role. And this is so common that it's impossible to really identify all those patients. And there was a number of questions in the chat. It's not just that we need to do a better job with doing Hcc surveillance in a patient known to have cirrhosis, but we have to start with who has liver disease, who has cirrhosis. Emmett also chime in, and we all know that a lot of these patients who present with cancer, they were not known to have liver disease until they present with cancer. But they actually, some of them have been in care. They're seeing the primary care doctors. Some of them even have been noted to have abnormal liver enzymes, but it wasn't significant enough for anyone to pay attention. And how can we leverage information that we already know? The patients who are not under care is much more difficult, but even the patients under care, we sometimes under-recognize cirrhosis so that we're not doing surveillance. So there are really a number of questions for which we need to do a better job of research. I'm hopeful that some of these questions, when we refine them more carefully, that NCI would find that they're worthwhile things to fund, because they're going to really require large cohorts to generate robust data. And I'm going to pause here so that Louis has some time to chime in.
Great, thanks very much, Anna. I'd like to thank Dr. Renato and Dr. Ward really for the opportunity to contribute to this session. I think everyone will agree that it's really been outstanding. I'd like to thank all the speakers for their contributions. I made a few just sort of highlight points from each of the talks that I think reflect some of the ongoing issues and concerns. So in terms of epidemiology from Dr. Mcglynn, I think she really highlighted the need for data on the burden of liver cancer, particularly in Africa. And I think that has to be a really important consideration there. In addition is the issue of prevention. And I think particularly in Africa, again, we have issues of implementing the birth dose of hepatitis B vaccination, recognizing that only 11 of the 50-odd countries in Africa have already implemented the birth dose. And this, of course, is about 35 years after we recognized that hepatitis B vaccination was important. So this is an important public health issue. It's important also, I think, as we think about Africa, to think about the need for studies that define who needs to be treated for HBV in Africa, particularly as we see, for example, with the predominance of HBV genotype E in Western Africa, that many patients have relatively low viral loads and an early transition to hepatitis B E antibody positive status. So I'll switch now to surveillance, and Dr. Sengel's sort of excellent presentation, and maybe just to highlight the importance of longitudinal surveillance, and that he pointed out, and that really sort of ties very much into Dr. Tayyab's talk, and the fact that there's so much to be learned from following individuals consecutively. And the fact that many experienced clinicians are used to doing this already. You know, they follow the AFP, and even if the AFP is initially low, they've been following the AFP over time, and that really helps them make decisions in terms of when is the AFP looking like it's abnormal. The other dimension to this is the observation that the AFP actually remarkably is a test that is getting better over time. It's like how wine matures with aging. And part of the reason, of course, is that we are able to now treat those patients with active hepatitis, whether it's active hepatitis B or hepatitis C. And what happens then is that we reduce the cycles of necrosis, regeneration, and repair that lead to non-specific elevations of the AFP in these patients. And as you treat and cure HCV, for example, what you see in that population is a suppression of alpha-fetoprotein, so that after a couple of years after cure, you almost never see those blips any longer. And when people begin to have a rise in AFP, it turns out to be real. And so much of the inconsistency that we've seen over the past few years in the performance of some of these biomarkers, I think, is tied to this phenomenon. I think it's really important, and was highlighted by Dr. Mehta and others, that ultimately, we tend to think of this cancer as one cancer, but really multiple subtypes of hepatocellular carcinoma, and so we need multiple biomarkers. And I think Dr. Chung really sort of highlighted from both hepatitis B and hepatitis C perspectives some of the underlying changes, and particularly perhaps the value of epigenetic markers, not only as biomarkers for diagnosis, but also as biomarkers for determining risk and for risk stratification. So lots of food for thought, I think, from this session. It's been really exciting, and I'd just like to thank the organizers and the speakers again for giving us lots to think about and lots to look forward to. Thanks very much.
Thank you. John, I don't know if your audio is working now, or.
You can try it one more time. Let me see if you can hear me.
You sound good. You sound very good.
I'll make it short so I can stay on the line, but just to thank all the speakers, and thank you so much, Louis, for an excellent summary, and thank you, Anna, for pointing out some ways forward, particularly when it comes to translating research into clinical practice and some of the challenges beyond HCC surveillance to really identify those persons at risk. So thank you all for an excellent discussion of an area of robust research, key opportunities to improve the health of literally hundreds of millions of people around the world if we continue to proceed in this way to improve both prevention of risk factors for HCC, as well as early detection of tumor appearance. We do have I think, one question survey for those on the line. If you'd like to give some feedback about the quality of the webinar today. Just to keep in mind, all of this information will be available on globalhep.org. That's the coalition website. So that will include all the videotape, the individual presentations videotape, the slide sets, and then there will be a synthesis connecting the important messages presented today. Also, while I have the floor, we will have upcoming webinars as part of this series in September. We'll be looking at hepatitis D, detection and treatment, as well as prevention. And then in October, looking at maternal and child health issues related to viral hepatitis. If you've registered for this webinar, you'll be receiving updated information about those webinars to follow. So in the interest of time, I want to thank Joanne for doing an excellent job of moderating. Thanks again to Betsy and all those on the organizing committee. Thanks to my colleague, Lindsay Hebert, who has been behind the scenes as the producer director of the webinar. And I want to thank again all the presenters and our panelists today. Thank you again.
Thank you all. Yeah.
Bye-bye.
Thank you, John.
Bye.
Thank you all.
Thanks.
Thank you.
Great job. Really enjoyed it. Thank you so much.
Thank you.
Thank you, Anan.
Thank you. Take care.
All right.